All right. Well, hello, ladies and gentlemen, and welcome to the Heartland Daily podcast, where today we're going to be talking about healthcare as we do a couple of times each month. My name is AnneMarie Schieber. I'm the managing editor of Healthcare News, and joining me is Devon Herrick. He is a healthcare economist who posts frequently for the Goodman Institute healthcare blog. Good to have you back, Devon.
Well, thank you. Good to be here.
Well, so much is going on, and I want to focus our chat today on four topics where we've seen some developments in the last couple of weeks. And those would be health savings accounts, price transparency, nurse practitioners, and medical board conflicts of interest. Now, the first item I want to chat about is because we do talk about this frequently, a lot of optimism about health savings accounts, given that now one party controls all the levers of power in Washington. And there is a lot of optimism that we're going to see some really big changes on HSAs. But I don't know. It's going to be really difficult because one of our big problems that at least President Trump is trying to tackle is government spending and healthcare having such a huge chunk of GDP. I looked at the latest figures. We spend $14,570 a person in this country for healthcare. That is a huge segment of spending, and much of it paid for by the federal government, i.e., the taxpayers. And if there's going to be a place to cut spending and reduce our national debt and our deficit, which is like, I don't know, $2 trillion, I think now, that healthcare is going to be one area under the magnifying glass. And already we're hearing screaming about it because, they're talking about Medicaid cuts. That's a discussion for another time. I want to circle back to health savings accounts and what is so wonderful about these vehicles. They're very limited right now. But what they do is they get money away from the insurance companies, get money away from the providers, and they put it into patient hands, consumer hands, who are much better decision makers about their healthcare spending than the government or a third party payer. So I want to point out Chip Roy, Representative Chip Roy from Texas. You probably know that name, Devon, from being in Texas. But he came out with a report a couple of weeks ago. And I don't know if, Andy, if you can pop that up. It's called The Case for Healthcare Freedom. And Chip Roy is a pretty vocal person when it comes to healthcare. And in there are various proposals for freeing up healthcare to possibly reduce spending. And, the thing is, there's no correlation between how much we spend on healthcare and the outcomes. Okay. Our life expectancy is actually going down in this country. And we have examples all over the world of countries that are spending less on healthcare and getting better results. So really, this is something that needs to be looked at. But in his report, he talks about HSAs. And, right now, I want to kind of take a look at what HSAs do. Chip Roy is proposing that we increase the contribution limits from $4,300 to $12,000 for individuals, which is a significant jump. And then there would be a catch-up provision for people age 55 to 65 up to $5,000. And the big thing is decoupling these plans from high deductible insurance. So that would allow some innovative healthcare models to enter the picture. So let me give you an example. I belong to a direct primary care center. I get excellent care from there, and I pay $100, less than $100 a month for it. That is totally out of pocket. I don't get any tax benefit from using that. But it's still so valuable to me that I don't mind that. But if we were to decouple HSAs from high deductible insurance plans, and I want to bring up another thing too, because another case came up on gig workers. I want to talk about that in a minute, but an article came out a couple of weeks ago, proposal by three heavy hitters in the healthcare space, Joel White, David Hyman, and Jiba, who are making a case for expanding HSAs to gig workers. And gig workers are huge because, I don't know, we've got something like 50,000 people who are in the gig economy, and they have really no good protection when it comes to healthcare. They can't qualify for employer insurance. And so what they propose is to allow companies to be able to contribute to an HSA for their gig workers. And then, of course, decoupling the plans from high deductible health insurance. Devon, why don't you step in here and talk about how important that would be, just that one step, decoupling HSAs from high deductible insurance plans?
Oh, it would be huge. I mean, just over the past several years, with me getting my own insurance, I have discovered that a lot of high deductible plans don't qualify for an HSA for one reason or another. I mean, you would think they all would, but I had to specifically look for a Obamacare plan of all, you know, places, one that specifically said this is HSA compatible. I mean, for example, if your health plan gives you a free doctor's visit, that disqualifies it. If your deductible is too high, that disqualifies it. And that's wrong, and it's really sad because, I mean, for most people who are in the individual market, Obamacare, have a high deductible. The bronze plans should all qualify, and well, so should most of the silver plans, but they don't. And so I think it's really long overdue to allow more flexibility, not just for those with Obamacare or individual insurance, but like you said, with gig workers, with people that have, care and sharing plans, those who choose to have the, direct primary care. It just doesn't make any sense to limit it. And of course, if you think back, what was it, 10, 12, 15, 20, how many years ago, it was a compromise that was fought out with the intention of limiting who could have one. And that's, especially now, that's really wrong.
Yeah. Like I was mentioning, my DPS, my direct primary DPC, I cannot use any tax advantaged money to pay for they're not premiums. They're not an insurer. They are a healthcare provider, a healthcare model, really. And so I know direct primary care people have been trying to allow HSAs to be spent on direct primary care to pay some of those fees, because they've been arguing they're not traditionally insurance. And right now the rules are, and if you really want to waste a whole bunch of time, go look up HSA rules on the IRS website, and you'll find a long list of tons of footnotes of what you can and cannot do with these things. So they're really kind of worthless to a lot of people, but they have so much potential. And, I cannot get the employer exemption, the deduction. So if you work for an employer, you get a huge tax advantage because your company, your employer gets what do they call the exemption, the tax exclusion for employers. So, how that works is they don't have to pay taxes on payroll taxes, in other words, so that you get a big tax break. You get compensation for your services that is not taxed, and that compensation then goes to pay for an insurance plan for you. And if you don't work in that space, you don't get that tax benefit. And so this would probably, to allow HSAs to be used for gig workers, would kind of even out the space and make it more fair, don't you think?
Oh yeah, if you think about the tax exclusion for some people, depending on where you live and what your marginal tax rate is worth anywhere from 35, almost 50%. It's like a half off sale, in terms of how much you're paying for, health insurance. If your marginal rate is 25%, well, the payroll tax that you're saving, employee share is 15.3. And then if you have state and local tax, you're getting close to 50%. So it would make a huge difference.
Yeah. Well, again, people forget that is your compensation. It's basically allowing your employer to spend your compensation. And while you get the tax break, imagine if, your employer came to you and said, okay, we're going to give you this money. We're going to put it in an HSA. We'll maybe put 20 grand in the account, and you go out and shop at your own. We'll provide insurance, but you'd have to pay for it. And, I just heard this phenomenal um, uh, presentation by Cato about a couple of hours ago. I don't know if Andy, you can pop that up. Tune into this. This was 3 hours of really good discussion on meaningful health reforms. And Michael Cannon at Cato talks quite a bit about how destructive the employer tax exclusion is, and if we were to eliminate it, how that could solve so many problems. They also had some discussion too about all the waste and fraud that goes on with healthcare spending, especially in the Medicaid space. So really good information there. And they talk quite a bit about HSAs. And, the idea that you would have control over your healthcare dollars, right now, think about it. Maybe Devin, you can explain a little bit how Obamacare works and how those subsidies kick in and go right to the insurers. They don't even go through the hands of the consumer. And it's a huge racket. And the insurance companies love it because they don't have to hound people for paying their premium, get the money directly from the federal government.
Oh, and that's the only reason really why people even enroll in Obamacare. Unless you're sick and have high healthcare needs. Historically, before the Biden administration expanded subsidies to middle class, it was primarily just those who qualified for subsidies.
Yeah.
And after the Biden administration expanded the subsidies, I actually enrolled in an Obamacare plan, and which is not any good. I mean, it's like if I had a heart attack, it would help me out, but for day-to-day medical needs, it didn't. And then last year, it's like we filed our taxes and our accountant sent back a note, oh, you owe just an outrageous amount of money. Well, come to find out, our pension, our retirement savings had changed. Something had changed. Some money we thought was deferred was not deferred. And all of a sudden I had to pay back about between $5,000 and $6,000 worth of subsidy. And I had not even gone to the doctor once. And that's not including what I had to pay directly, which is several $1,000s. So it's not a good deal. Well, except for the insurance companies.
I guess that's how we get to that 14,000, whatever it was, figure that we spent on each and every person in the country, over 330 million people, because there is so much cronyism and waste and fraud that we all pay for. And it's just out of control. It truly is out of control. And, the Obamacare subsidies are going to be coming up in Congress, I think this year, right? That's going to be a huge battle because right now they're very lavish. I think if you can qualify, there are stories of people who have a household income of over 200 grand a year can still get significant subsidies to pay for Obamacare. And the plans are not great, as you say. I know you and John Goodman have written quite a bit about the narrow networks and how these plans eventually ration care. It's always a race to the bottom with these things. And because they're forced to pay for anybody jumping on at any time with all kinds of health expenses. So it's just really a very poor model.
Well, last year, I ended up dropping out because it was such a poor deal that I signed up for an Obamacare plan through a hospital system. My old employer, as a matter of fact, many decades ago. And later I realized all the doctors were, most likely all hospital employees. And I thought, wait a minute, they're going to refer me to their own facilities. It's a money-making deal. It's not just making premiums and managing risk. It's probably a way to capture internally all the referrals to higher price providers. And I thought, I'm not going to pay this, and so I stopped.
That was another thing the Cato thing was talking about, because there is a really strong case. And in the beginning of that, they had 4 actually randomized controlled trials that show that spending more on healthcare doesn't make people better. And sometimes it makes them sicker. And, I think about this because I have adult children who have very generous employer health plans. and they're always going to the doctor because it's covered. They pay. And it's amazing. They're young people. And, every time you go to the doctor, you get a diagnosis, you get a treatment, they've prescribed something, and it's
Mhm.
overcare, in my opinion. But, they don't listen to me. All right. So I want to get into our next topic because it's sort of related to healthcare spending. And Ohio did something recently that I think is huge. And at first, I was kind of poo-pooing this, and because I thought we don't have realistic prices, why would anybody care to see what the hospitals charge on services? And it is stunning what actually happened. So let me kind of put this in a nutshell. What happened here? Ohio is the first state in the country to codify the federal health price transparency rule into state law. And I don't know, many of you might recall, but back in 2019, President Trump in his first administration put out
Good afternoon. This is Peter Baylor Credit Union.
a executive order on hospital price transparency, and then a rule went into effect on January 1, 2021, requiring hospitals to post all their prices for shoppable services. So those would be things that you would plan in advance, like a knee replacement surgery. And in theory, you were supposed to be able to go on a website, the hospital website, and could see the exact price for that procedure, how much it would cost. And the compliance in the last 4 years has been horrible because the Biden administration, while they seem like they were on board in enforcing this, they really weren't, and they kind of changed the rules. And of course, the hospitals had no reason to want to comply with this. They didn't want to post their prices, and they knew that consumers who are using a third party payer don't really care either. But that's kind of changed over the last couple of years because people are getting so many out of pocket bills, things they didn't plan for, surprise billing. I know you've written quite a bit on this, Devon, and maybe you can talk a little bit more about how what's been happening.
Well, it's for the first point is hospitals have always made it difficult to ascertain prices. And the reason is, as John Goodman has said for years and years, is because they're not competing on price. But I think it almost goes deeper in the sense they want to obscure price. They want opaque prices. They've resisted, they said, oh, we can't tell what Blue Cross pays us. We can't tell what Cigna or Aetna pays us. These are proprietary information. But there was a case I wrote about, it's from years ago, but a case in Colorado where a lady literally called the hospital and said, how much am I going to owe? Oh, you'll owe $1,300 and something. She got a bill for $230,000 because after the fact, the admissions office discovered that she was out of network. How do you even give somebody a quote if there's no network contract? It's impossible.
Right.
So, her health plan paid, I think, $75,000 approximately. And so they went after her for $230,000. And they sued her and she won. And so they appealed and then she lost. And then it took it to the Colorado Supreme Court that said, your fine print in your agreement is ambiguous and she doesn't have to pay. And that's the problem, is that hospitals really do not want to take the trouble or even reveal the information of what things will cost you because they're not competing on price. And they don't want you to be, they prefer you not to be able to exercise price sensitivity because you'd go elsewhere.
So let me tell you the beauty of this bill, of this law in Ohio. So the hospitals, if they do not comply with this federal law, they will be unable to go after, they will not be able to institute debt collection against patients. And the other thing, by posting their prices in a readable format, not estimates, not using a tool that, filters out gazillion things. It has to be readable stuff, machine readable files. What they can do, and I talked to someone from the patient rights advocate has really been working very hard on this, but they brought up another case very similar to the one you talked about, Devon, where they had a person who got 3 estimates 3 separate times from a hospital for a procedure. I think it was knee replacement or something. No, it wasn't, but for $3,500. When she got the bill, it was $70,000. So they were totally off. And what they did was they went back and they looked at the machine readable file that the hospital was supposed to put on. They found it and then they backed out finally because they had some accountability. They had to stick to the posted price. And that's the beauty of this. Even though you may not ever care about what the hospital charges, you can always go on and compare this. And then, the other thing too is you might be interested because if you have a high deductible plan, you are very probably price sensitive and you want to contain your, contain your spending. We know that people are willing to drive miles, travel to save a bundle of money in healthcare. So I think it would make the hospitals a little more responsive about the prices they charge. Don't you think?
Well, I think it would, but I think we need to go a little bit even further. There's a law professor named Barack Richmond that believes that the current case or contract law protects patients against surprise medical bills. Let's say there's a variety of reason why you might get a surprise medical bill, but suffice it to say that unless you get a quote, there really has not been mutual assent, or what is sometimes called a meeting of the minds. What we need to make sure is that patients aren't billed for things where they were never communicated the price. And if you're a hospital, you can give patients a price. You can give a binding estimate. I mean, yeah, you might be a few dollars off, but you really shouldn't be charging for Band-Aids. You should be charging prices that are closer to package prices. But yeah, to really make HSAs work and to make consumerism in healthcare work, we need price transparency. And to get that, we will have to make it within the hospitals and clinics' best interest, their self-interest to do so. And the way to do that is to say, unless you communicate the price, you don't get paid and you can't sue and you can't collect and you're out the money.
Yeah.
And that's the only way I think we'll ever get price transparency.
So Colorado in 2022 put the rule on. They didn't codify the federal price transparency rule, but they did create a law that prevented hospitals from going after patients if they don't post their prices. It's been very effective because the compliance rate went way up, according to patient advocates. And from what I understand, 4 states now, Hawaii, Pennsylvania, Oregon, and Washington, are also pursuing bills that would codify that federal rule. So all really good things. Legislators know that the compliance is very poor. It's something like 20% or under. And they know their patients are screaming about this. There's a rap star who started a whole campaign. What was it called? I think I can't remember the name of the campaign. Oh, Fat Joe. I don't know if that name rings a bell, but he has a campaign called Power to the Patients. It's very, very attractive. He's got rap videos, big, it's, empowerment type of, messaging, and it's ringing. There it is. I don't know. Power to the Patients. They got billboards mostly hitting, a specific demographic, urban areas, and, people in the lower income spectrum who are really hurt by this hospital pricing. So good for them. And I hope this really carries on and word will get out and more states will start taking this a little more seriously.
Well, I think it's an access to care issue. There are a lot of people that don't seek care because they are afraid of what will happen. If they just knew, even if the charge is high, if they just knew the price, they could make an informed decision, but they hold off until things get worse. And so it make a difference.
Yeah. I avoid hospitals for, like I will seek it out. I'll travel to Oklahoma. We, where I live, somebody did start a direct pay surgical center that does minor procedures that don't require general anesthesia, and the prices are all posted, and you know exactly what you're going to be facing when you get out of there. And I think that's just the way to go. Patients and consumers would really appreciate that transparency. So hats off to Ohio, and let's hope this does kind of create a trend throughout the country. The third thing I want to talk about is something that you posted this week, which I thought was real interesting, about nurse practitioners. So you discovered, New York Times reported this. Why don't you talk about it, Devon?
Well, if you think about it, most people probably did not even know what a nurse practitioner was before, say, 20 or 25 years ago. We didn't go to nurse practitioners. Now it's quite common. I mean, but the professor, or now well, she's recently, what happened was the lady that basically invented the role of nurse practitioner back in the mid 60s recently died at age 104. And the thing about it was that she did not ask permission of anyone. She went about it quietly under the radar because she knew she would face opposition. And so what'd she do? She was teaching nursing at the University of Colorado, and she quietly got a program started, to train nurses to do more than change Band-Aids, to take your temperature, to help you on the bed and off the bedpan. And it's had a huge effect, and it's definitely increased access to care. And now it's in fact, I think I even wrote this, that it was only a few years ago, physician's assistants, PAs said, no, we don't want the power. We're happy. But once they saw nurse practitioners getting more responsibility, they said, no, wait a minute. Now, hey, we want it too. So in fact, it is encouraged not just NPs, but PAs to also expand their scope of practice and fight for that expansion of scope of practice.
Yeah. And let's face it, not every issue requires the attention of a medical doctor. We spend a ton of money training them. It takes a lot of time, and they should be focusing their attention on the more complicated cases instead of like sore throats. And this is where these supplementary medical professions can really step in. You write about this quite a bit. Even pharmacists can be used more than we use them now. Physician assistants. And in your blog post here, you also talk about the graduates from medical school who don't get placed in residency programs. What a total waste. We need to find a way to use that training. And, a lot of it comes down to licensing. There's a battle brewing in California. I don't know if you got a chance to take a look at this, but the Pacific Legal Foundation is involved in a case involving California NPs. And a couple of years ago, California wanted to increase NPs. And one way to do that is to promise them that they could have practice autonomy. And so knowing that, because nobody wants to work under a doctor, and in many cases, they got to pay a fee to the doctor, and they're really restricted. So California kind of opened the floodgates. And recently, the Nursing Licensing Board, I think, is in charge of this, but they are reading this law in a way that has these independent, autonomous nurse practitioners having to go back now and spend 3 hours or 3 years or more under the auspices of a medical doctor so they can get their certification. And they divided them into two groups, 103 and 104. It's kind of complicated. There's a lawsuit involving it, but you can see the kinds of games that are going on in licensing.
Oh, absolutely. And this battle is going on in various shapes and forms all across the U.S. Initially, nurse practitioners got their start mainly in rural areas. It's areas that didn't have any practitioner, that no doctor wanted to live there. I mean, I grew up in an area like that in Western Kansas. And so it was begrudgingly, okay, you can work in, rural New Mexico, or you can work in the rural areas that nobody else wants to work. And of course, over time, it expanded to where some states began giving more and more practice autonomy. And there's two forms of practice autonomy. Well, there's really three forms. There's full autonomy where you can practice independently. There is what's called collaboration, and then there's what's called supervision. And some states, and I think Texas is one of those, that requires strict supervision, and it even limits the number of nurse practitioners that you can supervise. I think it's 3 or 4 is all. And whereas collaboration is more loose, it's a looser affiliation. And the tighter the requirements, the more money that the nurse practitioner has to pay her sponsor in order to practice. And as you can imagine, it's a turf battle, but it's also a monetary battle. If I have to work under you, you make more money. If you can hire 3 nurse practitioners, you're billing for them, you're taking a cut of their pay, and you may even be charging them an annual fee for supervising. So yeah, it does affect access to care. And then I'll agree that doctors have already voted kind of with their time and money that they don't really care as much about primary care. I mean, they are taught from an early age in medical school that primary care, pediatrics, direct patient care does not pay the same amount of money as procedures, surgeries or what have you. And so they're already abandoning the field for in great numbers. So I think we have a huge shortage of primary care physicians.
Yeah.
And so I think it is a great fit.
Yeah. Well, I think that they do certainly fill a need. And again, we struggle with enough doctors taking care of everybody. And again, we have also so much access to healthcare information that we really don't need to be running to a medical doctor for each and every healthcare problem. The thing about nurse practitioners is they can also instruct patients on how to manage their care better because they have the time to do it. So all good things. We'll be watching this case pretty closely and cheering on NPs and all these backup kinds of health professionals that help improve access to healthcare and reduce costs over time. All right, the last thing I want to talk about are medical board conflicts of interest. And there was an interesting case that came up in Texas. And when I saw this, it's a really complicated story. But what the bottom line is here, the medical director at the Texas Medical Board it was discovered inadvertently through a trial that he was being paid by Planned Parenthood, which is a huge conflict of interest in the state of Texas because they have a very stringent abortion ban. And the medical board does have authority over, charging doctors or going after doctors if they violate this thing. So there was a huge conflict that he didn't reveal, and it came out in this court case, and eventually he had to quit. But I think a lot of people, I don't want to get into the abortion discussion, but again, it goes to show you how these licensing boards can be used to manipulate healthcare and licensing and restricting healthcare in a way. What is your thinking on these licensing boards, and what would be good governance for them?
Well, I have always advocated that anytime you have a licensing board made up of the professionals being regulated, well, that's called regulatory capture. Pretty soon the board itself thinks its job is to protect its members, not protect the consumers. And so, I've always said, hey, really for, doctors and lawyers and even engineers and so forth, you need the professionals to be advisors, but not necessarily have the power to vote on their own, to regulate themselves, because you need some, of course, I'm a big fan of economists doing that, but I'm sure others might disagree. But yeah, the Texas Medical Board is one of the most aggressive medical boards in the country. If you look at the National Law Review, it says that they have gone against, providers for violating orthodoxy. They went after Teladoc years ago because they decided that before you could talk to a doctor on the phone, you needed to have a professional relationship. In other words, you're the doctor that you go to the clinic and see. You can talk to him or her on the phone, but you could not talk to a doctor you hadn't met. Well, that's protecting brick and mortar physicians from competition by somebody on the phone who didn't have a brick and mortar office. And thank goodness that was struck down in the courts and Teladoc won. And now you can go online and go on the website. And I've gone on the website and got medication after a very, simple type in the symptoms and tell some things about me. And a week later, a script arrives in the mail. I mean, that's a lot more convenient than going and waiting in a waiting room for 45 minutes and spending 10 minutes talking to a doctor and then driving all the way back home. So yeah, I think it's important that medical boards need to look at what is your mission. Your mission is helping patients and boosting access to care and having quality care, but letting consumers decide, patients decide what they want to do. I mean, several years ago, I think I told you this, that the head of the Texas Medical Board, it was found out that he was on a board that was fighting legislation to ban surprise medical bills. I mean, he had to step down from that board too.
Yeah.
and
Yeah.
because that is not appropriate. I mean, you're not there to protect, if you want to lobby for your profession, that's great, but don't be in a position to regulate. You either got to step down from the regulatory board or you got to back off from lobbying to protect your profession from consumers, from patients.
Yeah. And these boards have a lot of power. We saw this really to a huge extent during COVID. And some of the boards, especially Minnesota with Scott Jensen, who faced 5 challenges to his medical license. So Scott Jensen ran for governor. He was a state senator, but also a family doctor. And the politics there got so nasty. And he was a COVID skeptic. All right. So he was one of the first people to come out of the closet or just to really speak out on some of the COVID measures and some of the incentives that were happening that would force the doctors to do certain protocols involving COVID patients. He pointed out that the hospitals were getting kickbacks on admissions for people with COVID and putting people on ventilators and using remdesivir. And so he pointed all of this out, and they came after him with a vengeance. And that led him to run for governor. And then during that course, they came after his license 5 times. He prevailed. He fought off each and every one of them. But it just goes to show you how these licensing boards can be weaponized against detractors. And they also are, and not just in healthcare, but licensing board overall are turf protectors, right? So, licensing boards for hairstylists. We wrote recently in Healthcare News, Cato's done a study on this too, about lactation consultants. Now, several states are starting to license La Lesh, these consultants that moms use to help in the process of nursing. And now, what's going on. They're going to start commoditizing this, and it's going to be big business for some company that can afford the licensing fees and the training, and it's going to just drive up costs. There's no need really to have a licensing board for something we've been doing for decades, right? It's a very grassroots kind of thing. So, I think we just got to treat these organizations with a lot of skepticism.
Well, a few years ago, there was a case, I think it was in North Carolina, if I'm not mistaken, where the dental board went after firms that were storefronts that were doing teeth whitening. You can buy teeth whiteners over the counter. It's kind of cumbersome, but sitting in a chair, whether that be at the cosmetologist, your hair salon or whatever, some people were doing this, and they went after him and said, no, you're, cease and desist. This is the practice of dentistry. And luckily it was taken to the Supreme Court that said, no, this is not the practice of dentistry. You're painting on peroxide on teeth. It's, you can buy it over the counter, so you can let someone else help you with it.
Yeah. Yeah.
And we need more rulings like that.
Yeah, in my state of Michigan, we had a situation maybe about 10 years ago. I wrote quite a bit about it, but the technology was starting to develop where you could get eye exams online. They have
Yeah.
technology now that you can test your eyes and get a eyeglass prescription. And the optometrists in my state got wind of this, and they got a bill passed that now required anybody who could write a prescription for eyeglasses had to do this one thing that required a physical visit. So exactly what was going on there. And the company that was doing the high tech stuff was based in, I think, Illinois, and they didn't want to come anywhere near Michigan. They didn't want to fight those lawsuits. So it kept that out. And of course, now we all end up having to suffer. I think the prices actually have come down quite a bit for optometrists, but back then they were just simply protecting their turf. They wanted people to pay a couple $100 go into their office to get their eye exams, when that really was being, it was being phased out due to innovation and technology.
And hearing tests as well. I mean, audiology tests. Again, it's always a battle. First with the FDA and then with the state licensing board. Anytime you try to make something more convenient, even if it's possibly not as high a quality, oh no, that doesn't count. You got to come into an office and spend hundreds of dollars. You can't have a headset on that tests your hearing, or a website that tests your eyesight. And it really does affect patients, because those who want to go to their optometrist would still go, and those and another example is hearing aids, of course. And those who don't want to go would opt for a cheaper option, maybe, if they had the choice, but in many cases they don't.
Yeah. In my state, we still have a rule that you have to get you can't get an eyeglass prescription filled that's under 2 years old, which forces you to go get an exam every 2 years. And, maybe there's some reason for that. That's fine, but it shouldn't be a law. It should be up to me, really, to decide that. But, again, that's what licensing boards are all about. Well, we have covered a lot of ground, and we could talk for hours on all these things developing. Is there anything that you're kind of keeping an eye out for? Certainly what's going on in Congress and the federal level and the budget cuts, anything that you're looking at?
Well, I'm kind of wondering about the regulatory shakeup. I'm wondering if maybe, hopefully, the people at HHS take have time to look at issues like you and I were talking about, down at the consumer level. Now, I say consumer because ultimately even if we're patients, we're all consumers. And I know there's some big picture items that they're all working on. I mean, big grants and Medicare and Medicaid. But I hope they have time and make the time and make it a priority to help patients become better consumers, and not just focus on the big picture items that are in the news, like Medicare Advantage and Medicare spending and so on.
Yeah. I'm going to be watching the Medicaid battles, because, the tax cuts are getting a lot of attention, and already it's turning into a battleground, and there are threats of going after particular legislators for voting against or for Medicaid cuts. And I think, maybe the tax cuts there'll be a deal somehow or another where we get the tax cuts, but we leave Medicaid alone. I hope it doesn't come down to that. But I think a lot of people we're all watching for that, and we'll see how it pans out. All right. Well, good deal. I think we'll stop right here, and thank you again, listeners, viewers, for tuning in. And we'll be back next time with, I'm sure, 100 things to talk about. So until then, stay healthy and stay well.